Good day, and welcome to the CAP webinar entitled The Proposed 2027 Medicare Policy and Payment Changes for Pathologists. During the next hour, we'll discuss the proposed regulations and policies for the Medicare Physician Fee Schedule and the Quality Payment Program that will be used to reimburse pathologist services in 2027. Before we get started, I'd like to review a couple of technical details about today's presentation and introduce our presenters. Please type in your questions during the presentation. There will be time at the end of the presentation for our panelists to address them. We will select questions that are a representative sample of those submitted during our limited time here today. An archive recording of the webinar will be available later this week. The CAP will have a link to this presentation in our webinar section at the cap.org website. Now let me take a moment to review our agenda and introduce our presenters. Next slide, please. Your moderator for today's webinar is Pamela Yazdani. Ms. Yazdani is the Senior Director of Economic and Regulatory Affairs at the CAP's Division of Advocacy, located in CAP's Washington, D.C. office. Next slide, please. Our first presenter is Dr. A. Joe Saad, Chair of the CAP's Council on Government and Professional Affairs. Dr. Saad is also a member of the CAP Board of Governors, Chief of Pathology for the Methodist Health System in Dallas, and Adjunct Associate Professor of Pathology at the University of Texas Southwestern Medical Center. Next slide, please. Our second presenter is Dr. Ronald McLaughlin, who is the chair of the CAP's Economic Affairs Committee and a member of the Council on Government and Professional Affairs. Dr. McLaughlin is also professor and vice chair of pathology, head of the Division of Laboratory and Genomic Medicine, and director of the clinical laboratories at University of California, San Diego, and U.S. San Diego Health. Next slide, please. And our final presenter is Dr. Gregory Bucci. Dr. Bucci is the chair of the CAP's Value-Based Programs and Healthcare Policy Committee. Dr. Bucci is an associate professor of pathology at the University of Colorado School of Medicine. And now it's my pleasure to turn the presentation over to Dr. Saad.
Well, thank you, Ms. Yazdani, and welcome everybody to today's webinar. The agenda on the screen is as indicated. I will begin by giving a brief overview of the payment policy and advocacy position of the CAP. Next, I'll turn it over to my colleagues to cover the proposed 2027 fee schedule changes and the proposed 2027 quality payment program policy. After that, we'll have some time for questions, and then I'll wrap it up after that. Next slide, please. So just a brief overview of the CAP payment policy and advocacy agenda. In July of 2026, on July 14th of 2026, CMS released the proposed 2027 Medicare Physician Fee Schedule and Quality Payment Program regulations. That afternoon or early evening, CAP members received a special advocacy update with an initial analysis of this regulation. Today, we're going to go into more detail. The comments are due on September the 14th, so we're within the 60-day window for comments. We will continue to engage the Centers for Medicare and Medicaid Services during this comment period and after the comment period. The final rule is expected in November, usually around the beginning of November, but sometimes it's come out as late as Thanksgiving. The proposals could then be implemented on January 1 of 2027. As many of you know, you've seen this graph before. There's a growing gap between Medicare pay and inflation. This has been updated for 2027. The last one you saw showed a delta of about 33%. However, this gap continues to increase. We will be approaching 38% next year. This is a result of continued inflation in medical practices and decreased Medicare payments for our services. Next year, we anticipate expiration of a 2.5% from the One Big Beautiful Bill Act passed last year. They gave us a bump in the Medicare fees for this year. So we anticipate a decrease of about 2.4, 2.5%, plus inflation continues, and it's estimated to be about 2.5% for next year. So the delta by the end of 2027 over the past 10, 11 years is going to be a 38% decrease to our payments. This is unsustainable. We need to continue to tell Congress to tell Congress they need to give us a short-term fix while pressing for a long-term fix, which would include an inflationary update to the Medicare fee schedule. As you know, this was a major ask at our Hill Day this past April. Next slide, please. The CAP, AMA, and other physician specialties will continue to push Congress hard to fix Medicare cuts for good. This gap is unsustainable. Part B payments on the Medicare fee schedule are not adjusted for inflation. Part A payments are. So hospitals, skilled nursing homes, ambulatory surgery centers get an inflationary update every year. Physicians do not. The AMA estimates that Medicare physician pay fell 26% between 2001 and 2023 because physicians did not get this yearly inflationary payment update. Next slide, please. With that, I'm going to turn it over to Dr. McElhaughan to go over some specifics.
Thank you, Dr. Saad, and good morning, everyone. So let's talk about the proposed 2027 physician fee schedule. Could I have the next slide, please? So there's a lot to tease out in the proposed rule. CAP is looking at 11 different items. I'm only going to cover about 4 or 5 that are relevant here. So as Dr. Saad has already mentioned, the expiration of the congressional relief from OB3 at the end of the year, the conversion factor is proposed to decrease by 1.7% in 2027. The proposals announced in this release have the potential to impact pathologists both in the long term and the short term. In the short term, on average, we're looking at around a 2.4% decrease in 2027. For pathology and in independent laboratories, there'll be about a 2.5% decrease. I'll first talk about what is changing for 2027 and how it will impact pathology payments. Following that, I'll focus on the significant long-term threats to pathology that are not currently captured in our impact calculations. Next slide, please. So, for 2027, CMS is continuing to split the conversion factors based on whether there's a physician is in a qualifying advanced pathology alternative payment model, an APM. As required under MACRA from 2015, physicians who are qualifying participants in APMs will receive a slightly higher conversion factor update and thus slightly higher Medicare payments in 2027 compared to physicians who are not in QPs. Both conversion factors are adjusted on a positive budget neutrality adjustment, largely resulting from proposed work RVU changes. This is about 0.53%, coming from reduced payments for certain E&M visits with modifier 2025. So for 2027, proposed conversion factors for qualifying APM would be $33.17. Non-qualifying APM conversion factor would be $32.84. Next slide, please. So one other thing that's in the proposed rule is a proposed change to the practice expense methodology. There are 3 changes actually being proposed, and rather than getting into all the very technical issues here, I'll not cover them in detail. So I'll just focus on their impact on our pathology payments. Overall, the changes will have a negative impact on pathology payments. One of these changes is the increase in expenditures for a large number of non-pathology services. That's both work RVUs and clinical labor RVUs. To offset this increase and to maintain budget neutrality, pathology payments will decrease. The next thing that's occurring is the removal of the practice cost index, indirect practice cost index, the IPCI. This is expected to have a negative impact on pathology payments, but the exact impact will vary code by code. The next slide will show the combined effects of these various changes going on in the practice expense methodology for the most commonly billed pathology codes. The CAP is concerned that CMS is making significant changes to this methodology for practice expense without significant physician consultation. The CAP will continue to remind CMS the importance and the need for physician input on these changes. Next slide, please. So here we are looking at the top pathology services, mainly surgical pathology, special stains, and immunohistochemistry. This is summary for non-facility payments for the top pathology services. As seen that, particularly in the technical component, which is more susceptible to the changes in the indirect practice expense methodology, these will be the areas that receive the largest decreases. The variation in change across technical component payments also reflects the variable impact of removing the IPCI on pathology services. Next slide, please. So looking at the pathology services overall, which ones are showing the biggest increases and the biggest decreases? Well, you can see on the top 5 increases, there is a significant increase in the fine needle biopsy codes. This was a code that, 2 codes that were revalued recently at the RUC. And this is largely being driven by a new piece of equipment, an upgraded ultrasound equipment. Work RVUs slightly decreased for the 06 code, and then slightly increased for the 05 code. You can also see microdissection, morphometric analysis, in situ hybridization. Those are all that show increases. Below, you can see the ones that show the greatest decreases, the intraoperative pathology consultations, immunofluorescence, and then some related to transfusion of blood components and photophoresis. Again, this is non-facility reimbursement for pathology service, and we'll see these are the largest increases and decreases we're seeing in 2027. So, next slide, please. So, the most concerning aspect of the proposed rule for us is the surgical pathology codes 88300 to 309, which have been identified as potentially misvalued by the Maryland Healthcare Commission. Particularly the 88305 and 307 codes as being potentially misvalued. MHCC sent a letter to CMS back in February looking at 13 different CPT codes outside of pathology as well, but 88305 and 307 were nominated by the Maryland Healthcare Commission, where physician service were providing these services more than 8 hours a day and 24 hours a day. They based their calculation, particularly on the 88305, based on 25 minutes of intra-service physician time associated with this code on the PFS. The nomination of the 88307 was also included, but this then opened up the MHCC to recommend the CMS to look at the entire code family, 88300 to 309. CMS believes that empiric data will be a better indicator of physician work relative to the AMA RUC survey data. Therefore, CMS is seeking widespread comment on whether RVU changes should be applied as early as 2027. The CAPs will remain steadfast and will urge CMS not to make any changes for 2027 and to follow the normal CPT RUC valuation processes. Next slide, please. So a little bit more on the MHCC study. So the Maryland study used 2023 claims from the Maryland All-Payer Claims Database and estimated the total time associated with pathology services reported for individual providers on a given day. Or CPT code 88305, they identified 1,763 days where physician time exceeded 8 hours and 587 provider days where it exceeded 24 hours. Now, recognize this is a very small percentage of the total. It's only 2.9% of the provider days exceeding 8 hours. Based on the findings, the commission suggested that physician time currently assigned to 88305 by the RUC may be overstated. 88307 had 40 provider days exceeding 8 hours intra-service time, which represents only 0.4% of the provider service time exceeding 8 hours. Another aspect of this study that MHCC did is they pointed out that gastroenterologists and dermatologists were also frequently billing the 88305 code while exceeding 8 hours a day. Then MHCC referenced the 2016 Urban Institute study suggesting 2 minutes of intra-service time for 88305 versus the current 25-minute RUC value time. The identification of a small number of unusual provider day totals by itself does not demonstrate that 88305 are misvalued. Given the small prevalence of the occurrences, these findings do not represent a systematic valuation issue here. Next slide. CAP has identified several issues with the Maryland study. We have already touched on being an outlier study and not reflective of the typical 88305 service. But we also must note that Maryland did not present a detailed methodology. Therefore, the CAP cannot verify whether the analysis accounted for the unique characteristics of pathology practice and billing, including data service. The CAP reiterates that it does not believe Maryland identified a valuation concern. An outlier study should not be used to evaluate the typical service provided by pathologists. The CAP stands ready to participate in the CPT RUC process and to defend the valuation of these codes and the entire surgical pathology family. Next slide, please. So our surgical pathology advocacy is CMS should not make any changes for 2027 and follow the CPT RUC processes to approximate the value of physician services. So CAP has developed an extensive advocacy plan that includes detailed written comments and meeting directly with CMS. That will occur next week on August 20th. We have also worked with the AMA, other specialty societies, and other stakeholders to educate them on the issue and raise awareness of the significant flaws in the Maryland study. CAP is also preparing to engage with Congress to ensure that patient care is not compromised by changes that are not supported by sufficiently validated evidence. We recognize that surgical pathology family will be reviewed by the RUC in the near future. Therefore, the CAP is committed to ensuring that our members understand the RUC survey process and be prepared to participate effectively. I would encourage you to scan the QR code here to understand, for all our members to understand the CPT RUC process and to understand the RUC survey process. when the time comes for revaluing the 8300 to 309 code family. Next slide, please. One other thing that occurred within the proposed rule for 2027 is, and it was also something that was noted in the hospital outpatient prospective payment system rule as well, which was the creation of something called software as a medical service, SAMA, or SAMS, to be distinguished from SAMDs, software as a medical device. These particularly was focused on 10 clinical laboratory codes that are being moved from the clinical lab fee schedule to the physician fee schedule. These are largely PLA codes. There is one code 81416, which is the category 1 CPT code in this grouping. They're doing this because CMS is doing this because they do not need to be performed in a CLIA laboratory facility. To be payable on the CLFS, the service must be performed in a CLIA regulated facility. They're distinguishing the use of SAMs on laboratory results rather than SAMs being performed in a laboratory facility. CMS is also concerned about the transparency of the cost data set in these services. CMS believes improved payment stability and predictability. These services should be moved to the PFS, where they will be subject to beneficiary cost setting, sharing, and PFS budget neutrality. The CAP has several concerns with this proposal. While we recognize CMS's concerns related to CLIA, the CAP does not believe the PFS is the appropriate long-term home for these services, and SAMs outside the lab space in the hospital payment prospective payment system rule also talks about alternative ways to deal with SAMs, but that would require a legislative solution to create that. So CAP believes SAMs services are not equivalent to professional physician services and should not be funded using the PFS budget. Moving these services to the PFS will only contribute to continued downward pressure on physician and pathology payments. Next slide. And lastly, part of the proposed rule contains a request for information and RFI on the CPT and the CPT RUC process. Particularly, they're looking at the AMA's CPT coding system, CPT licensing, the CPT code development, and the RUC. This obviously has been a subject of discussion, which I think everyone's been aware of with the HHS Secretary, the CMS Administrator, and various members of Congress. The RFI seeks comment regarding the AMA's role in licensing CPT-4 and the potential for conflicts of interest arising from a reliance on a private organization in the process for recommending physician service values. The RFI asks 5 questions, which seeks general input from the public. CPT licensing costs and effects, the role of medical necessity in code development, possible alternatives or supplements as the National Physician Services Code Set, alternate governance and valuation processes, and whether physician service should instead be paid using ICD-10 PCS or other bundled payment approaches. So this is really something that would disrupt the entire coding and valuation process that we've relied on for years for our pathology services. So next slide. So with that, I'm going to turn it over to Dr. Bucci, who will review the proposed changes in the quality payment program and MIPS requirements for 2027.
Thank you, Dr. Mohan. So overall, the CMS is proposing one major change to the merit-based incentive payment system, along with some other minor changes, and we'll review those proposed changes now. So if you go to the next slide, please. Since the implementation of MACRA, there have been two arms of the quality payment program, the merit-based incentive payment system, or MIPS, and alternative payment models, or APMs. MIPS is the default arm, but CMS has always stated that their goal has been to move all Medicare beneficiaries and therefore all clinicians into APMs and out of MIPS. Over the past few years, the CMS has advanced towards this goal by creating another branch of MIPS called MIPS Value Pathways, or MVPs. And they believe that MVPs are a bridge to HPMs because they create a more unified, aligned set of measures and activities compared to traditional MIPS. As we'll discuss more detail in the future slides, the CMS introduced pathology-focused MVP in 2026, and the CMS is now proposing that effective year, calendar year 2029, traditional MIPS, that is the MIPS that many of you know and love, will end, and MVPs will be the only MIPS option. We'll get into the details of this too, and how it affects pathology practices in just a few moments. If we can go to the next slide. Let's talk about what's not changing for 2027 first. As you can see on the left side of the slide, the CMS is not proposing any changes to the performance threshold or to the payment adjustments. In order to avoid a negative payment adjustment, individuals or groups will have to earn at least 75 points. Scoring higher than 75 points will therefore lead to a positive payment adjustment. In theory, the maximum positive payment adjustment is plus 9%, but because MIPS is budget neutral, high payment adjustments haven't panned out. There are just too few MIPS participants getting negative adjustments to fund the full 9% positive payment adjustments. The other aspect of the program that isn't changing for 2027 is the performance categories. MIPS is composed of four categories: quality, cost, improvement activities, and promoting interoperability. For programmatic reasons, single specialty pathology practices are rarely scored on cost or promoting interoperability, and that just leaves quality and improvement activities. The CMS is aware that small practices can have challenges participating in MIPS due to a lack of infrastructure and staff to support reporting. And for that reason, CMS makes allowances for small practices, and that includes weighing quality and improvement activities equally at 50% each. This only applies, though, to practices with 15 or fewer clinicians. Practices with 16 or more clinicians have quality weighed at 85% and improvement activities at 15%. And so that remains unchanged. Next slide. A positive for pathologists is that CMS is proposing to maintain favorable scoring for our publicly available QPP measures. As many of you may remember, the CMS considers these measures topped out, meaning that the performance is high and there is limited room for improvement in many practices. Now, once a measure is topped out, its maximum score can be capped at 7 points. However, CMS recognizes that there are not very many measures available for pathologists, and because pathologists have limited measure availability, the CMS has removed the 7-point cap for these measures, meaning that they're worth up to 10 points again. As you can see on the right, these measures are scored against a flat benchmark, so practices must perform very well to get the maximum points. However, compared to these measures being capped at 7 points, this is a real improvement. One note, because QPP 491 is still relatively new, it's not topped out, so it's also worth up to 10 points, but it isn't subject to that flat benchmark table that you see here. Next slide. Now, here's a significant change. The CMS is proposing to change to what measures practices must report. And this applies both to traditional MIPS, as long as it remains available, as well as to MVPs. Currently, practices must report at least one outcome measure, and if an outcome measure is not available, a high priority measure. Because there are no outcome measures for pathologists, practices must therefore report a high priority measure. Most of the existing pathology measures are designated as high priority measures, so finding a high priority measure to report hasn't been a particular challenge. However, CMS is now proposing to revise the requirement. and to terminate the high priority designation in favor of a new designation called core measures. Per CMS, core measures are measures that are most reflective of the care that is central to a specialty. Now, CMS has made this determination, themselves without our input. And on the right, one thing you'll notice is that there are 3 core measures for pathology, which is fewer core measures than high priority measures. And so, that is concerning. However, a preliminary analysis indicates that most practices will be able to report one of these measures, but probably not all. So to address this, the CMS is also proposing a mechanism by which individuals or practices who do not have an applicable core measure can attest to that fact so that they are not penalized. So if you do not report a core measure and you don't attest to there being none that are applicable to you, then you will receive 0 for that measure. That means in an MVP, you will get 0 on 1 out of your 4 measures, or in traditional MIPS, 0 out of 1 of your 6 measures. So that attestation could be very important. Next slide. Now we come to probably the major change that CMS is proposing, and that is sunsetting traditional MIPS outright. As you can see in this graphic from CMS, MIPS value pathways, the MVPs, are available for many clinicians now, and they have been for several years for various clinicians. Currently, reporting MVPs remains optional. However, starting in 2029, MVP reporting would be mandatory for those in MIPS because traditional MIPS would no longer be an option. MVPs have some similarities to traditional MIPS, as well as some notable differences. And one note is that there are several features of MVPs that do not currently have a significant effect on pathologists, including the ability of groups to form subgroups. Now, as these MVPs become more relevant to pathologists, the CAP will certainly be developing resources to assist practices in understanding how to maximize their scores in MVPs. Let's turn now to how MVPs apply to pathologists on the next slide. And we'll start by discussing where MVPs are the same versus different from traditional MIPS. Like traditional MIPS, MVPs include quality, cost, improvement activities, and promoting interoperability categories. Most of the activities in these categories are in fact the same as those activities exist in traditional MIPS. But each MVP contains a subset of the entire set of measures and activities. So the MVPs also add another category, population health. Those measures are calculated by CMS from administrative claims, so no additional data submission is required proactively for the population health measures to be scored. The quality, cost, and improvement activities in each MVP are specified for each MVP. For instance, the dermatological care MVP may include a cost measure covering melanoma resection and a measure about skin cancer and inflammation, while the pathology MVP would include things like RQPP and QCDR measures. Conversely, the promoting interoperability and population health measures are the same in all MVPs, and every MVP includes the promoting interoperability and population health measures. Now, as in traditional MIPS, only the quality and improvement activities categories are key to the pathology MVP. PI, cost, and population health measures do not apply to most pathologists. And so the CMS has stated that the same reweighing policies that applied in MVPs as did in traditional MIPS. However, since 2026 is the first year of the pathology MVP, we don't know for sure how reliably the CMS has reweighed these categories for pathology practices. Since cost and population health measures rely on attribution by CMS by our codes, our expectation is that pathologists will not be attributed in these categories, but will not see information to know for sure until next summer. Let's review the measures and activities that are proposed for the pathology MVP, which is the MVP I think most people are most interested in. We'll go to the next slide. So here are the measures and activities proposed for inclusion in the 2027 pathology MVP. Because the PI and population health measures don't apply to single specialty pathology practices, we're not listing them here. However, the complete list is available on the CMS's website. That's qpp.cms.gov if you'd like to refer to that. As you'll see here, the pathology MVP includes all of the publicly available QPP measures, as well as some QCDR measures from the CAP's Pathologist Quality Registry, and some measures from a commercial QCDR. There are a number of improvement activities in the pathology MVP, but not all of them are usable by single specialty pathology practices. For instance, improvement activity BE26 requires the use of patient-reported outcomes tools. This would be very difficult for pathology practices to do. In addition, in the past 2 years, the CMS has removed several improvement activities that were regularly used by single specialty pathology practices. And so to counteract this, and to ensure that there are sufficient improvement activities available for pathologists, the CAP has submitted proposals for new improvement activities for CMS's consideration. And I am very pleased to report that they have accepted 2 of our proposed improvement activities and included both of those in the pathology MVP as well as in traditional MIPS. The titles of those improvement activities are highlighted here. And CMS made some minor modifications to one of the improvement activities that we proposed to ensure that it would be a little bit more broadly usable by a cross-section of clinicians other than pathologists, but they also accepted one improvement activity as written. With regard to the cost measures, there's only one cost measure in the pathology MVP, but it doesn't apply well to pathologists. It's Medicare spending per beneficiary. Since this measure is rarely attributed to pathologists, we'll not get into the details other than to point out that for one to be attributed to this measure, a pathologist must bill evaluation and management codes in a hospital inpatient setting, which is not something that's commonly done by most pathologists. If we move to the next slide, I'll discuss a little bit about what CMS is proposing related to alternative payment models, or APMs as we know them. So first, a reminder of how payment for practices who are in APMs has changed over the years. As you may recall, when QPP was new, there was a 5% lump sum bonus to APM participants. This was intended to sunset in 2024, but was extended by Congress several times at lower levels. Then the Consolidated Appropriations Act of 2026 extended the APM bonus yet again and raised it to 3.1%. Importantly, this is not a proposal for 2027. This is in effect now in 2026, but the CMS has noted it in their 2027 proposed rule. At the same time, APM participants also receive a bonus in the form of a higher conversion factor. So starting in payment year 2026, practices participating in APMs, as determined by CMS, will receive a plus 0.75% increase in the conversion factor. And this continues year on year, meaning that the conversion factor for APM participant goes up faster than for MIPS participants. Clinicians who are still in MIPS do receive a 0.25% increase, though. The change that CMS is proposing for 2027 in terms of APMs has to do with how they determine who is in an APM. The CMS makes this determination themselves, and so it can be hard to know who is in an APM and who isn't. So starting in 2026, CMS has been making this determination at the NPI level, so at the level of the individual clinician. This means that a clinician who is identified as a qualifying APM participant, or QP, is considered a QP at all practices if he or she works at multiple institutions. The CMS believes this is resulting in incorrect payments to some practices who are not actually in APMs, but whose clinicians are QPs at other institutions. Therefore, the CMS is proposing to make determinations going forward at both the combined NPI and TIN, taxpayer identification number level. And that is the determination for each clinician at each practice. This is, in fact, how MIPS eligibility is currently determined. If they do that, this will result in lower incentives or bonuses for some TINs who are not in alternative payment models, but who have QPs, because they will no longer receive the bonuses for the clinicians who happen to be QPs at other practices. But they also feel that reduction is appropriate because the payments were potentially improperly made. We'll move to the next slide. So as part of the commitment to independent pathology practice, the CAP continues to develop and maintain pathology relevant quality measures and improvement activities, and importantly, the pathologist quality registry. And the registry supports several mechanisms for data entry, including working with practices directly or billing companies to help maximize their score in these programs. CAP registry staff are honestly excellent. They'll talk with your practice to help you navigate MIPS, figure out how to maximize your bonus potential. And as scoring gets more complicated, it's increasingly important to understand how to score best. Most pathology practices can score best by using the pathologist quality registry and the quality measures that it supports. And for those of you that want to know, who rely on your billing companies to make these determinations and want to know more, ask them to reach out to CAP on your behalf. The CAP's QCDR measures really should be an important consideration in terms of the scoring strategy. And you need to understand the availability of the highest scoring measures. And that's easy to do because you can contact CAP staff at MIPS at cap.org to learn more about how to report them. Next slide. In addition to that excellent personalized support from the registry and quality team, I also get to introduce the PQR agent. So this is a new resource on the CAP website designed to provide quick and reliable answers to many of the common questions CAP receives about PQR participation and MIPS reporting. So, whether you're looking for information about quality measures, improvement activities, or just general reporting requirements, the PQR agent can help point you in the right direction, and it draws the information from current CAP guidance. It's intended to serve as a convenient first stop resource, allowing pathologists to access information when they need it. However, every practice is different. In some situations require more individualized guidance. And so for, your complex, nuanced, or practice-specific question, of course, the registry and quality staff are available to provide that same expert support that, CAP members have come to expect. As MIPS reporting requirements evolve, our goal is to make the trusted information more accessible, also continuing to provide the personalized assistance you need to help practices maximize their success. So I would encourage you to explore the Pathologist Quality Registry agent on the CAP website and use it as an additional tool to understand what's going on with MACRA and the Pathologist Quality Registry. I will stop there and turn the presentation back over to Dr. Saad for questions.
Thank you, Dr. Rucci. I'm going to turn it over to Ms. Yazdani to moderate the questions.
Thank you. Thank you, Dr. Saad. So we will now take your questions. And if you have not already done so, please feel free to type them into the chat feature for us to answer. Our first question is for Dr. Saad, and it is, I'm combining a couple questions we received actually. The first is there anything I can do today to help protect CPT code 88305? And also, we had a member asking for advice for pathologists on how they could comment to CMS on the proposed rule and what CAP's approach was for that.
Yeah, thanks for that question. This issue is not going to be resolved overnight. We have a short-term strategy and a long-term strategy to address this issue. It is a top priority of the CAP to protect our CPT codes for the pathology services, beginning, of course, with our base codes in the 88300 to 88309 family. Obviously, special stains, immunohistochemistry, et cetera, will also be part of our goal to protect them as well. Um, so right now, we are preparing our comment letter to CMS, which is due on September the 14th. It will be an extensive letter. We're working with the committees and council within CGPA and advocacy staff in Washington, D.C. And it will be a very comprehensive letter. If you have any stories, issues, data, please reach out to CAP and we'll incorporate them into the letter if appropriate. We're asking you not to reach out individually to CMS at this point. We'll be working within CAP and with other organizations to coordinate our letters to CMS on this issue. So for the time being, please let us know if you have any stories or issues. Don't reach out individually. Obviously, as this progresses, we may ask you to reach out individually to Congress, for example, if we have to do outreach to Congress. And as it goes to the RUC process through AMA, we'll be reaching out to you to respond to the surveys that will be prepared, the typical vignettes on what an 88305, for example, service entails. And so we'll be sending out educational material. I think a link was posted earlier in the chat, and we'll be sending out more educational material as that process approaches. But for now, our primary goal is for CMS not to move forward with any unilateral changes in 2027 and to allow the RUC process to take its course.
Thank you, Dr. Saad. The next question is for Dr. Bucci on the quality payment program. How are the core measures identified? Can we ask CMS for more core measures?
Yeah, thanks. CMS has stated that the core measures were selected based on whether the measure is an outcome measure, the availability of measures, whether measure adoption, how many people are using it, and whether the measure is reflective of care that is central to the specialty. But for measure by measure, they didn't really weigh, what got it designated as a core measure. The good news is that all of the pathology QPP measures are widely available and highly used, so that criteria would be satisfied. What we really don't know, because this is just brand new to us as well, is exactly what CMS means by most reflective of care that is central to the specialty. That's not very specific, and the basis for that determination is at present unknown to us. So we can certainly make the case to CMS that more of our measures meet that classification. It does seem that they intend to keep the number of core measures low, but I guess our general approach is to ask for exactly what we want and push that as far as we can and see how far we can go. Like I mentioned, we proposed improvement activities that they accepted. And so they do accept, things that we propose. And I would imagine that if we make a strong case for an outcome measure, they'd at least seriously consider it.
Thank you. Our next question is for Dr. McLaughlin, and it's regarding the CPT code 88305. This member is concerned about this issue and asking, is CMS actually proposing any changes for the code for 2027?
Well, thanks for that question. I'm sure this is on the minds of a lot of our members. So technically, no. But there are some caveats here. CMS has not proposed at this point a specific change to the physician time or work RVU for CPT Code 88305. However, the proposed rule does seek broad comment on whether changes in the physician time and work hour use for 88305 and 307 are warranted in calendar year 27 based on the Maryland Healthcare Commission's analysis. This creates a lot of uncertainty and has raised the possibility of making changes without specific revised values for stakeholders to evaluate. However, the CAP does believe CMS should not finalize changes until to the physician time or work reviews for these services in the final rule when it comes out in November, without first proposing specific values and then allowing for stakeholders to provide the opportunity to review and comment. Without the comment, this should not go forward. CAP is actively responding, as we've noted already, to the nomination, strongly believes that any reevaluation of these services should only occur through the established RUC process and not be done unilaterally by CMS without having input from stakeholders on specific values.
Thank you, Dr. McLaughlin. The next question is for Dr. Saad. And this is a question, it pertains to the chart that we showed earlier about the widening inflation versus payment gap. And the question is asking is when can this become unsustainable for pathologists?
So yes, obviously, any gap is unacceptable as far as CAP is concerned, and we will fight for every bit of reimbursement that we can to stay within medicine and to stay within pathology. A lot of things are out of our control. We will continue to fight for an inflationary adjustment to the Medicare fee schedules, given the increased practice costs that we're facing, and we'll continue to fight against decreased reimbursement from CMS. However, the CAP does not have a specific threshold at which, we throw up our arms and say we can't go on any longer. That's an individual practice decision. The CAP will fight for every bit that we can. But obviously, the effects on our practices could be, very detrimental, could be catastrophic. Some practices may close. Some of this is leading to consolidation within practices. Some of it is leading to being acquired or bought out by hospitals or other entities within pathology. So individual practices obviously do have a break point that would make it unsustainable. For CAP, every bit is important, and we'll fight for every bit that we can to keep within medicine and pathology.
Thank you, Dr. Saad. The next question is for Dr. Bucci. The question is, where can we obtain the details of the 2 new IAs that were accepted?
Yeah, well, so the advocacy news email that was a special edition sent on July 14th had the details of the 2 activities, included in the message. They haven't been specifically identified in terms of getting a code from CMS. But if you saw on the slides, it's the use of data to improve practice workflows. And there, the idea is using practice performance and operational data to identify workflow improvement opportunities and enhance the efficiency and the quality of care. And then the second one is understanding and improving diagnostic performance. And so there, the idea is that the practice would be evaluating diagnostic processes and outcomes to support continuous quality improvement, improve diagnostic accuracy, and strengthen patient care.
Thank you, Dr. Bucci. The next question will be for Dr. McLaughlin. And we received some comments regarding the Maryland study. And some of those comments were that the problem is that CMS thinks that the 88305 workflow is continuous. And the comment was that it's combining 2 days of work into one. I don't know if Dr. McLaughlin would like to comment on this inquiry that we received.
Yes, be glad to. So I think, we've stated, we're going to assemble our comments, and they're very detailed comments to CMS, talking about this issue, talking about the flaws in the Maryland study as well, and areas of concern such as data service, provider identification numbers, who's making these claims, filing the claims for these services. But this is why we need to go back through with CMS and really talk at length with them about how these codes work, how they work in specific practices and for specific services. This is why the RUC process is so important, and the RUC surveys, because they do take into account those factors. And that's what we need to reiterate in our letter, a comment letter, and in our meeting with CMS officials. This is discussed when we do present evaluation of our services at the RUC. And that is the value of retaining the CPT RUC process. So I think there's a lot of things that are kind of tied together in the proposed rule. They're interrelated, and relying strictly on empirical data, other kinds of data, rather than through a survey process and walking through the steps is key for our advocacy position here. And going forward, not just on the 88300 to 309 family, but as Dr. Saad said too, eventually we will be dealing with the special stains, immunohistochemistry, same process. This will all need to be restated, how they go over multiple days, multiple blocks, as the person who asked the question talked about, the blocks of TC versus PC kind of components. So all these things have to be explained and detailed and reemphasized with CMS.
Thank you, Dr. McLaughlin. There's just one question I can answer quickly. If the webinar is going to be available to CAP members in a recorded format, and yes, this will be posted on the CAP website, and actually it will be available. I think it's linked to YouTube as well, so it will be available to others. And the next question is for Dr. Bucci we received on the QPP program. It says, a couple of years ago, CMS was pushing to make all measures digital measures. Is that still happening?
Yeah, briefly, yes. In addition to all the other things that they proposed that we talked about today, the 2027 QPP proposed rule also includes a request for information about transitioning quality measures to a new digital standard called FHIR, F-H-I-R. There are a variety of issues with trying to use this standard for pathology data because so much of pathology data is unstructured. The CAP has been looking at it, and continues to monitor these efforts, and has engaged with the CMS and other regulators to ensure that we just want any transition on digital measures not to impose an undue IT or administrative burden on practices. So CMS has not forgot, and we're keeping an eye on it and responding to them as they develop their thinking around that.
Okay, thank you, Dr. Bucci. Let's see, I think we have time for one more question. The next question is for Dr. McLaughlin, and it is it says that looking at the list of codes CMS proposes to move off of the clinical lab fee schedule, I'm concerned that at least one of those codes does not meet CMS's definition of software as a Medicare service. What's the CAP's position on this issue?
Sorry, Pam, I heard part of it. It clipped out, but
I'm sorry. It's regarding the software as a medical service, and
yeah.
that one of the codes doesn't appear to meet the definition, and what CAP's position on this issue.
Okay. So again, we will identify this in the comment letter, but we also are going to advocate for CMS to convene multi-stakeholder groups to review these and comment, because they're doing this strictly on the basis of the code descriptor. And they do not have the background information. So we're asking that CAP and other relevant stakeholders evaluate these services to determine whether they meet CMS's definition of a SAMS for laboratory analysis performed on a laboratory test. So that's our approach, but we will also identify individual codes in the 10 that were out there as examples in our comment letter.
Thank you. That's all the time we have for questions. So I'll turn this back over to Dr. Saad to finish up the program.
Okay, well, thank you all for attending. We're 1 minute past. I'm just going to take a few seconds to close things out. First of all, there's a question about the Maryland healthcare study. That is publicly available. If you go to their website, you can have access to that. If I was more coordinated, I would have posted a link in the chat, but you can find it on their website. Just to close out, please be sure and follow the CAP on social media. Our X/Twitter handle is at CAPDC Advocacy. Please follow us on Facebook and visit the cap.org advocacy page for a lot of information there. Also, look in your inbox every Tuesday afternoon for the Advocacy Update newsletter. And please join PathNet, which is the CAP's grassroots advocacy network. So thank you very much for your time and enjoy the rest of your day.